Vinayak sir, sir kindly unmute.
Yes, sir. Ram Gopal sir, you can start as chair. First, welcome message, and then we'll start. Unmute, sir.
Ram sir kindly unmute.
Yes. Good evening, friends. Welcome to one more episode of Casebook Live. As the name suggests, and you are aware that we would be discussing a live case which is actually handled by our moderator. And again, the diagnosis is not important. Approach to the case is important. And for that, today we have our experts. I welcome Dr. Sara Dhanawade, madam, and Dr. Vinay Joshi, sir. And today's PG students are Dr. Pratima Patil and Dr. Rupali Naidu. Welcome. And I welcome Dr. Niveda Patil. She is the mentor of these PG students. Welcome, madam. Over to you, Vinayak, sir. We can start.
Okay. Good evening, everybody. As we know, this is the 6th episode of Casebook Live. Every month, first Wednesday, we discuss one interesting case. The pattern all of you know, just to remind all of you. I go on presenting case. We'll take pause and ask approach and differentials about to the first PG students. And according to their answers, we go on asking the experts in this field. I'm very happy to have two experts today, Dr. Sara Dhanawade, madam. First of all, she is Dean of the Bharati Medical College, and more important, she is my PG teacher. Second is Dr. Vinay Joshi, sir. He is DM neonatologist as well as pediatric intensivist. He's a national, both the madam and Vinay are national faculty. We also thank Dr. Nivedita Patil, madam, for being mentoring the PG students today. And without wasting much time, I will start sharing the screen and start the session. So today we'll discuss one different interesting case. This is last 4-5 cases we have discussed about slightly older children, infant and other. Today we have a neonatology case. So 28-year-old primary with 28 weeks pregnancy with PIH and PV bleeding. She has the baby was grossly intrauterine compromise was there. So planned for emergency dialysis. Baby cried immediately after birth, male baby. Weight was 1.07 kg. Within half an hour till we reach NICU, baby has started grunt with intercostal and subcostal retraction. So this was the X-ray at admission. Baby required because of baby required intubation, and these are the investigations. So my questions to PGs is, what is happening to this particular baby, and how will you interpret this thing? Just over to PGs. Yes.
Yes, sir. So this is a 28-weeker, which is an early preterm, and it is a spontaneous spontaneous delivery. Hence, I guess the mother has not received any antenatal steroids. Also, the X-ray is suggestive of respiratory distress syndrome, is suggestive of hyaline membrane disease, and also the ABG is suggestive of low PO2, and I think we should, yeah, that is it for now.
What do you think? What is what?
With intubation and as well as we should consider for giving surfactant.
So what is the physiological status of this baby, and how will you interpret this blood gas? This was an arrival at admission blood gas.
Respiratory unconscious.
Physiological status we can categorize as respiratory failure.
Okay.
And ABG.
How do you correlate with this FiO2 and PO2? What is the pH? What is the PCO2? Comment on lactate. Is how you interpret, na? Just answer like what, how you are doing this, managing this case in your routinely in your NICU. What do you think? What is happening in X-ray? Just interpret this X-ray.
So we see homogeneous opacities of near whiteout lung, which
Yes.
is correlating with the hyaline membrane disease and also with the period of gestation at which the baby is born.
Okay.
So, it is an indication that we should be giving surfactant to the baby, as the physiological production of surfactant must be very less.
Okay. Just comment on other factors. pH, PCO2, lactate.
pH is 7.43, so it is in the normal range, sir. And PCO2 is 20.3.
Okay. This what do you think? This lactate. What this lactate indicates? This babies with background of intrauterine compromised.
Lactate is raised.
Okay. So just this is a compensatory
hypoxic
respiratory
injury
alkalosis
also, sir.
with hypoxic. Can you calculate PF ratio in this case? FiO2 is given to you. PaO2 is given to you. Okay, P is very easy. So first, with this background, I will come to experts now. I will come to Madam first. Madam, what do you think? What is happening to this baby, and what is how we should go about this? Madam, unmute yourself.
Yeah. So we have a background of a preemie who is 28-weeker, born with respiratory, with grunt, and the setting is suggestive of RDS, probably not received steroid, as the PG student rightly pointed out. So coming to the blood gas, it shows hypoxemia and with the compensatory respiratory alkalosis. And obviously there is a high lactate here. So probably I would think that whether the baby has shock, whether he has suggestive, which is suggestive of hypoperfusion. So I would say probably the baby has RDS, respiratory failure, and shock.
So this is how the baby was, as Madam has pointed out. So this was at admission, because we were expecting this baby to have, because diastolic flow was not there, physiological, this is lot of compromise was there. Yes, Vinay, you want to what? Yes, Vinay.
Can I say some?
Yes, please. Yes.
Yeah. See, and of course, this is a early preterm, 28-weeker, almost close to extremely low birth weight, around 1070 grams. But there is very significant history in this child. One is the PV bleeding. I think I would love to know amount of bleeding, when it started, what is the cause of bleeding, because the important thing here is we have got lactate 4.17, which is pretty high. Of course, you know, that you will expect in the baby who is acutely compromised. Probably this is what happened in this child. Okay. And the important thing is the duration, since when the PV bleeding started.
It was around 5 to 6 hours.
Okay, so I think that is one thing, and the amount of bleeding, what is how it was. And what is the cause of bleeding? Because this child was delivered by spontaneous vaginal. Was there any anterior placenta? All those things I would
delivered by LSs.
Yeah. Then they will come to know whether it is a anterior placenta, and that is because that is a risk factor for antepartum hemorrhage. And some other more information, like the antilinal steroids, we assume that they were not given. They were not given. Okay, so I think these are the few things I would like to ask before get into that, because many times this X-ray, if you ask the differential diagnosis, we have to keep this in mind. It could be even pneumonia. Why it is not pneumonia? Because we are the first differential will be a hyaline membrane disease, because we have micropreemie born at 28 weeks without any antilinal steroids, and emergency LSCS because of antepartum hemorrhage. So this is what we have. So probably it is HMD and the higher on the list. But at the same time, we should look at, something whether we have
Other possibilities also.
other possibilities as well.
Yes, yes. Agree.
Also, if you look at the hemoglobin, it is just 13.9 for,
Yes, yes.
So
So
the
that
bleeding has
suggests
been
some, that suggests some bleeding is from also.
baby
Female
side.
side as well.
Yes, yes, yes. So this was a baby has received surfactant. We put on PC mode 14/16, 6 FiO2 0.6, IE ratio 1. After 6 hours, distress reduced, lung compliance improved, perfusion was improved, and this was the thing at 6 hours. So this was the baby just quite pink, well perfused. If you see, the lungs are also put here. Lactate has reduced. Can you interpret this blood gas, PGs? Yes.
pH is reduced, so it is an acidosis. That could be
So the pH is 7.3 and PCO2 is 44.7. Although the significant thing here is still the hypoxia of PO2 is 70.
Yes.
If it is SO2, if we could get, still there is hypoxia in the body, sir.
What do you think? This is acceptable limit? With a FiO2 0.545, this is baby is ventilated. So what do you think? Are you okay with this, or any more intervention you want at this stage? This has now mixed respiratory acidosis and metabolic acidosis.
Yes.
Any intervention you want, or just you want to wait for while to improve?
So we can wait for some time. If the PO2 continues to be the same, I think we can increase the FiO2 on the ventilator.
Okay, okay. Madam, just what do you take on this stage? How will you go about it? Any intervention you want at this stage?
No, I think the baby has improved clinically. The distress has come down. Of course,
Yes.
on the blood gas, yeah. With 0.4 FiO2, the PO2 is 70, but the pH is acceptable range, 7.32. So I
Yes.
would probably continue.
Okay. Vinay,
this.
anything from your side?
No, I think we are good. Rather, I'm very happy with the gas.
Yes.
The way it slide.
So
And
just important
for the
take here is not.
PG,
Yes.
Yeah. When we say that it is that your PO2s are still on the lower side, or pH is just that's more than 7.3. One should remember that we are not ventilating a normal lung. Okay,
Yes.
once we keep that in mind, then we have to accept the optimal blood gases, optimal numbers. They may
Yes.
not be the perfect ones as given in the book. So we should look for the optimal numbers, optimal pH, optimal CO2, optimal PO2, all those things.
Yes.
Okay, so if it is acceptable blood gas, very happily
Yes.
I'll take this gas and
Okay.
keep quiet.
Okay. Okay. So we'll move forward. 18 hours. Again, baby had now desaturation, SpO2 88 with FiO2 just we increased to 0.45, but despite it, distress is increased. Now abdomen has distended and visible bowel loops are here. So PGs, what is happening to this baby? This is how the baby is. 6 hours he was okay. Now 18 hours, this baby has started like this. So what will be your approach and how will you go about this? Yes, PGs.
So the X-ray is suggestive of
X-ray was suggestive of hyaline membrane disease. We have ventilated this child. He was all right till this time, and 18 hours this thing has started. So how will you take this thing? Acute onset deterioration. And any baby on ventilator, how will you take it?
So first we'll see what are the pressures because these babies are very susceptible to the barotrauma if we are ventilating with high pressures.
Okay.
Second thing, if there is any spontaneous pneumothorax, so we'll check for any air entry, reduced.
So what you want to say, dope, na? Yes.
Look for dope, sir.
Yes.
First, get the desaturation.
Okay.
And then
Anything
because
else?
abdomen is distended, we can also think of NEC because it's a preterm and we haven't given steroids.
Okay.
We can also think
Just
of that.
one doubt, sir. Had we started any feeds, minimal feeds?
Yes, one feed of 1 cc we test feed we have started for this baby.
Okay. So we can keep NEC also in our mind, sir, when
Okay.
such a picture is.
Which do you think, which component is more you should be worried about, NEC part or lung part?
So lung
The lung
part,
part,
sir.
Okay. So what just from experts, madam, first I will come to you, then I will come to Vinay. At this stage, what do you suspect?
Yeah, as they rightly said, we should look for dope. But
Yes.
given the setting of this preterm baby, I would really consider looking at the patency of the doctors at this level when they have a baby
Yes.
with RDS who deteriorates like this.
Yes.
That
Yes.
should be high on the card and most probably the first thing you would think of.
Okay. Vinay?
Yes, I think his 18-year-old child, preterm, no ANS. So first, whether the duct has opened up, that we should be thinking in terms of, but I'll keep my pneumonia in the
Okay.
mind,
Okay.
because many times when you have background pneumonia, baby will initially respond to your surfactant therapy. Again, then the picture will emerge.
Okay.
So we have to keep that in mind while doing this. And of course, NEC, I think I would, right now I won't think of, because it's too early. If you look at the incidence of NEC and when it comes to preterm babies, usually it happens in the later part.
Yes.
Yes, sometimes we can see in the term babies, rather we see earlier when they go on full feeds and formula feeds, etc. But not in the preterm babies. It is possible, remotely it is possible sometimes, but I don't think so.
Okay.
And if
So
you're
this is
thinking pneumothorax, it is not spontaneous pneumothorax, by the way. It is iatrogenic, the way we are ventilating. So one should look at dope and exclude pneumothorax.
which is with this now expert has given you hint. Any investigation you want to do at this stage? PGs.
We can go for 2D echo, sir, to look
Yes.
out.
And anything else? Okay, 2D. This was the X-ray. Can you interpret this now? Just you comment on this X-ray. You have seen previous X-ray. Now comment on this X-ray and blood gas. Just you have to go fast. Lot of things needs to be covered. We have to go till 50 days. So yes, anything?
Metabolic acidosis is there,
Okay,
sir.
first talk about X-ray. What is happening to this child?
Sir, again in the left lung field, we see that there are haziness and rather.
Yes. There is air bronchogram.
Yes.
Yes. About a blood gas.
About
what
the
is
blood
happening?
gas, sir, it is, I guess, metabolic acidosis. Not much of acidosis is said, but still hypoxia is there, sir, as compared to the previous
Previous one. What
gas.
has happened to lactate as compared to previous?
It has
Lactate
increased,
has
sir.
raised.
It was
Yes.
2, here it is 3.6.
So this is metabolic acidosis, high anion gap, PF ratio here is 80, and AA gradient is 400. So just we'll see for, this was the cranial USG also we did. We did echo also. Simultaneously we did cranial USG. Do you have any time interpreted cranial USG or seen or point of care ultrasound? Have you gone across? So just we'll quick take from Dr. Vinay. Yes, Vinay, anything take on cranial USG?
Yeah. See, but the cranial ultrasound looks pretty okay. There is nothing remarkable. What you would suspect in this baby being a preterm on ELBW, bleed. That is
Yes.
the first thing which should come to your mind. And
Yes.
sometimes babies who have bleed, they can present with acidosis.
Yes.
Okay.
So that's what we did. We got
Yeah.
very small grade 1 germinal, but I was not contributing. This was MCA things were also okay. RI index was also okay. And this was the echo. I will run both echoes and then we'll ask. Yes, you PGs, have you seen, this was taken from the screen photo, but it's not very good quality. But still, anything you can say about this PGs? This was the echo we did.
Yes, sir.
Yes.
Sir, in the echo, the screen that we are seeing on the right side,
Yes.
there we see that the systemic flow and there is shunting back. So which is suggestive of an open ductus arteriosus.
Yes. Yes. More than on left side, what you see? Which is view? What view is this?
Yeah.
This is a 4-chamber and 5-chamber. Both views have been seen. Anything you see in that? So this was the interpretation. This was dilated LA, LB, left LV dysfunction was there, dilated RA, moderate pH, and this 2.5 millimeter PD.
See, I think for the PGs, here you can see the duct, which is entirely, you can see the red, right?
Yes.
It means it is flowing left to right.
Yes.
There is a good pressure gradient between aorta and pulmonary artery, and that's why
Yes.
you're only unidirectional, that is left to right shunting.
Yes.
And this is the reason why your lungs are flooded. That is
Yes.
the reason you can see the lung volumes have become small.
Yes.
And your respiratory ventilator requirement have gone up. There is metabolic acidosis, but just one significant left to right shunt because of the PD explains your ABG, explains your X-ray as well.
Vinay, what about this dysfunction? Is it contributing to this PDA or something else also is there?
See, I'm looking at two things. One is his RA also dilated, RA and
Yes.
RA both.
Yes.
You can
Yes.
see, and of course the LV dysfunction is there.
Yes.
Now, LV dysfunction, I think we'll have to look at the actual numbers where it is saying 40%. But
Yes.
right now, I think we are not in we don't have any hypotension building up there. We are not requiring any inotropes. But you
Yes.
can
Yes.
keep that in mind
Yes.
because that is the next thing, because even lactic acidosis can be explained by this. So
Yes.
lactic acidosis may be because you have significant left to right shunt, it may be because of your LV dysfunction affecting the cardiac output and the organ perfusion.
Okay. So with this, we increase the ventilator settings. 20/7 FiO2 was increased. We put it on dobutamine, adrenaline, Lasix, and paracetamol was started. And within this next 18 hours of this thing, what we did get this baby. So this respiratory distress had settled. This was the X-ray, and this is the blood gas. Just now comment from PGs. So within say 18 hours, this baby has, from previous X-ray, this baby has come to this condition. So what is your take? How will you interpret these investigations?
So the child is still in metabolic acidosis with
Yes.
Mixed acidosis.
but the PO2 is increased, improved
Yes.
than before, and the X-ray is also has improved than
Yes.
before, but there's still tachypnea which we can contribute to metabolic acidosis.
So this was the thing. Then at 60 hours, yes, mild, again, baby had developed distress at this stage. SpO2 was dropped. Then FiO2 here was 0.4, heart rate was 160. And here now we have developed significant distension of the abdomen. Visible bowel loops were there. DT aspirate was here, 3 cc brownish. Baby was significantly reduced output. And now what we observed with baby is not passing urine in stream. Baby was passing urine in drops. So just see the video and then we'll see what is. So now with this 36 hours, okay, now 60 hours, this kind of thing is there. So how will you approach now? What is the status of this baby and how will you approach now? Yes.
So, at this stage, it doesn't look completely to be a respiratory component. I guess there is some GI component also involved in it, and which is
Yes.
both are contributing to the metabolic acidosis and shock. Also, the reduced urine output we can attribute to the poor renal perfusion, which can be an impending AKI. Also, we need to get a renal function test done to rule it, to get an
Okay.
idea about it.
Yes. Yes. So how will you investigate at this stage?
So first we can get a blood gas done, an erect abdomen X-ray,
Okay.
a renal function test done, and
Okay. Anything else? Common thing?
electrolytes, blood.
Yes. More
Elec-
common, anything else when you get this kind of distension, preemie, 36, 60 hours, lines are there.
A blood culture.
Blood.
Before that, blood CBC you want, na? CBC,
Yes,
CRP,
sir.
all basic
CBC,
investigations.
CBC.
Sugar, all these things you want, na?
Yes.
So we investigated this child. So this was the X-ray. Can you interpret now? Comment on the X-ray. Anything significant you see in this X-ray? Okay, with only visible bar, dilated loops are there. This is CBC. Anything comment on CBC?
BBC, WBC is on the lower side, sir.
Yes, CRP is negative.
CRP is negative.
Platelets are on lower side. Yes. Now you were asking about urea creat that has raised.
Yes, sir.
Yes. Now lactate has come down, and this is the blood gas.
Yes, sir. So acidosis and thrombocytopenia, sir. I guess it will be two of the components of NEC triad, what we say.
Okay.
So the sodium levels aren't that deranged to fit that into the triad.
Okay.
Whereas on X-ray, we see that on the right side, the loops are pretty distended and they look classically like how they would look in NEC. So.
Okay. Now I will come to madam. Madam, at this stage, what is happening to this baby? And how will
I
you
think,
know about this?
I know. I think he has the, still the respiratory distress is continued. In addition, the baby has developed a new problem, two new problems, I would say. One is related to the GI, like he's got abdomen distension. We are having the stool occult positive and low platelet, low count. So definitely that point towards NEC. And also baby has pre-renal AKI at this stage, probably because he has got decreased urine output. And both NEC and pre-renal AKI, we can explain on the large ductus and the ductus steal syndrome and probably the systemic hypoperfusion, which is going to the tissues, gut as well as to the kidneys. That would be my take here.
Okay. Vinay, what is your opinion at this stage?
Yeah, I think as Madam rightly pointed out, and even the registrars have told that there is a high, the way that the picture looks like it is, child has sepsis, NEC, going into metabolic acidosis, and the picture fits into that. I think, again, we should go back to our history and see we had PV bleeding to begin with. That always keep in mind. So that is the risk factor for whatever we are dealing with now. And the sepsis should be always clear. That should be on your mind when you're dealing with these kind of babies. Okay. And of course, and the steroids are not given. Again, that's why the baby is prone for NEC as well. So looking at the X-ray abdomen, there is nothing specific features on this apart from the distended bowel loops right now. Maybe when you do the serial X-rays, probably we'll see some fixed loop somewhere, or you'll see, the other features of NEC. So that the most important thing is one X-ray will not tell you what exactly it is. You have to do the serial X-rays in different position. I prefer to do many times left lateral decubitus, so that if the air, it can come up and, you can easily pick up that. If it is the peritoneal air.
He's just dribbling urine. Any investigation you further want to do? Because he has not passing urine. He was passing in drops.
So this is a male baby, no? So PU valves or anything, we should think of any kind of obstructive uropathy.
Yes.
Yeah.
So PG, madam has given you hint. Any investigation you want to order at this stage?
Some micturating cystourethrogram.
Will you go for this preemie 1.1 kg baby on ventilator? First, what things you want to get it?
What immediate thing you will do?
USG abdomen.
USG abdomen.
Yes.
Yes. So we did USG abdomen, and this is like this. So now see the USG and now tell ki how will you do? So what it says, mindfulness in pelvic alysyl system, secondary to over distended bladder, and it is causing a compression and displacement of both loops of bowel loops to the periphery. And if you see the X-ray also, it looks like that. See, these things are being deviated on one side.
See can I say something?
Yes.
The moment you see the child has gone into sepsis, septic shock, NEC, and we are supposed to monitor urine output.
Yes.
And many times, if you're seeing the dribbling urine happening, first thing you do is get the suspect posterior urethral valve.
Yes. Correct.
Get the surgeon involved and put the catheter in.
Yes.
You can do the sonography, later on, whatever. But I think the first thing you need to do is intervene.
Yes, yes. So we, as Vinay has really pointed out, we did pediatric surgery because, and we were also in dilemma to go for whether to, because we have never seen this kind of uh, preemies having MCU doing at this stage because on ventilator and so much things. So we did intermittent. They put it as infrequent voider due to prematurity. So we did intermittent catheterization for almost two to three times. And then after that, baby started voiding well. NEC was started with FFP, Econom, and Metrogel, and other supportive management was done. Ventilation inotropes were weaned over 4 to 5 days. Repeat echo also shows improvement. PD was close, moderate. Still, there was mild to moderate pulmonary arterial hypertension was there. This was on day 8. This was 960 grams, 70 gram baby. On nasal CPAP, distension has decreased, baby passing urine well. DT fits was started. GIR on 7, baby was maintaining sugars also with only addition of Metrogel. I think part of NEC also is taken care. Count has improved. But urea was almost same, 86, creatine 0.7, 136, and CRP was 0.4. Anything in the X-ray PGs at what this stage? What do you think? What this baby is settling? Whatever parts what we have discussed problems, do you think it has settled at this stage?
Yes, sir, it looks so because the lung fields are pretty clear, and even
Yes.
in the gut loops are also not distended.
Yes. What thing has not settled is urea and creat,
Yes.
isn't it? So still that part is on. Now it is day 8, but still not urea creat is not settled. Madam, take from you at this stage. Are we really worried about this urea creat at this stage?
Yeah, I think is it the urine output is normal? Urine
Yes,
output
yes, it is normal.
and the ultrasound is also not showing anything much.
Ultrasound has not shown anything. Kidney size and both PI and RI of arteries are also normal. Renal arteries are also normal.
So what happened to the ductus status at this stage?
Ductus has closed, ma'am. Closed.
Ductus is closed.
Okay.
So this could be part of, the renal injury could be part of the definite. It looks like pre-renal. Could be
Yes.
because of the fluid restriction and probably the Lasix which you have given, and all this could have contributed. I would wait and watch if the urine output is okay. I would not intervene at this point.
Okay. Vinay, what is your take?
Yeah,
Or
I think it's
KPI part?
the rise in urea is because of the volume contraction. I
Yes.
think because of NEC, I think we have there is a lot of the intra-volume losses,
Yes.
and that must have led to the high urea. Creatine is coming down. That's a good sign. So I think
Yes.
over a period of time, if we adjust the fluids properly, the things will come down on its own.
Correct. Okay. So we'll move further. This was meanwhile our newborn screening test reports have come. So it's pretty normal. So both fatty, almost all things are within normal limits. So day 16 we were quite happy, but till day 14 we were happy. Weight was also okay, activity fair, tolerating feeds up to 10 cc. But now day 16 baby had apnea and 2 episodes of desaturation. But baby picked up on the own. We did repeat cranial USG. It was almost same grade 1 germal GMH. BSL was 42. So just GIR was increased to 9. This was the electrolyte. Now at day 16, urea has come down, as both experts were saying we have to just keep watch. And we did sepsis screen also, negative. Now the question of from me to the PGs is, so day 16 episode of apnea, this was 28-week baby, grade 1 GMH, same thing. So is there anything you want to do extra at this stage? Or what will be your approach at day 16 for this baby? Yes.
Sir, we would first think of sepsis, but the screen is negative.
Yes.
Maybe any intraventricular hemorrhage, but the cranial USG is not suggestive of any increase in hemorrhage.
Yes.
Neither are the electrolytes suggestive of any dysfunction.
Yes.
Just one thing which is low, that is BSL is 42, to which we have responded by increasing the GIR.
Yes.
So hypoglycemia can be one thing for now to
Okay.
point out.
Yes.
Mm.
Anything at this stage, any investigation you want, or just you okay, you are okay with this patient?
Mm. No, sir, we cannot think of any specific investigation. Just if we have to focus on hypoglycemia, maybe if it is not still responding to the 10% dextrose bolus or
Okay.
increase in GIR, we'll do
We
the
did blood gas at this stage. Blood gas is like this.
It is again suggestive of metabolic acidosis, sir,
Okay.
because of 7.2.
Yes.
And lactate is also
Will
high.
you give, are you, this day 16 apnea, what is your routine take at this stage? Otherwise, baby's cry activity is fair. So what apnea you will call it as? What are the different types of apnea you get? Obstructive?
Obstructive
Yes,
mixed.
apnea of prematurity, convulsive apnea, no.
Mixed.
So where do you put this patient, baby at?
So most unlikely to be prematurity, because at day 16 it is very unlikely to be because of prematurity.
Now baby is now 30 weeks, no? 28 preterm.
Yes.
Okay, anyway, just we'll shift to, we'll ask our experts. Madam, what do you think at this stage happening? And then we'll go to Vinay.
As they said, I would also first thing would have thought of sepsis on day 16. A baby, I suppose this baby was on caffeine? Or,
Yes, he's on caffeine. Yes.
So that sepsis would be high on the card, although the sepsis screen was negative.
Yes.
I would still keep that on the because
Yes,
it's
we send
small
blood
baby.
culture at this stage.
Yeah. Second, you are getting some low sugars. I would even be worried whether the baby has meningitis or anything when the baby has apnea at this stage,
Yes.
On day 16.
Yes.
So the USG is not showing any increase in the bleed.
Okay.
So then metabolic would be another thing. And
Okay.
something which is worrying on the blood gas is that the baby still has acidosis. There is no reason, actually, the baby who is clinically improving and
Yes.
well, but baby continues to have this waxing and waning, and he has some acidosis, and the lactate also has again gone up to 3.57.
Yes.
And with that borderline sugar, we should be a little bit concerned about
Okay.
anything happening to this baby other than sepsis.
So this was here, this acidosis is normal and gap. This was something which was surprising to us. With some respiratory acidosis component is there because baby has been, but no hypoxemia. So PGs, this is normal anion gap metabolic acidosis. AK has been settled. So what do you think? What are the causes of normal anion gap metabolic normal anion gap metabolic acidosis?
First cause could be dehydration.
Dehydration will cause normal anion gap. There are very specific causes, na? Low or normal anion gap metabolic acidosis. Okay, we'll move further. Just will not. This was then day 21. Feeds reached up to 15-16 activity fair. There was no episodes of apnea, similar MCT, and other added things were there. Intermittent reading. It was getting low sugars. So what we thought, we just went on increasing the GIR up to 10, and then baby was maintaining these sugars here. But day 24, baby had desaturation, grunting, nasal flaring, marked abdominal distension, poor perfusion, capillary filling time now 4 seconds, taken on CPAP. After CPAP with FiO2 of 0.6, saturation is 94, PEEP 6, and heart rate is 164, and this is the baby at day 24. So how will you investigate this stage, and what are your possibilities at this particular?
So by looking at the video, it looks more like acidotic breathing. One
Yes.
thing. Second, the baby has gone into shock with poor perfusion.
Yes.
So I would say sepsis would be still again on the first on the list.
Yes.
Second can be metabolic. So we are suspecting some
IEM.
kind of IEM.
Okay. More
Possible.
than that? So we did investigation at this time. This is because I will give you the investigations. So more than this. So this is how the baby is on day 24. Comment on X-ray.
So the bowel.
Again, this yes, this LV dysfunction. Today I don't have echo at this particular juncture, but LV is definitely reduced. Rejection fraction is moderate. TR now. Moderate RA was dilated. Moderate pH was there. CBC was 12.1. CRP was negative. Urea 45. Anything else you want at this stage? How will you manage this case now? You know now day 24. These investigations, how will you manage? Or anything else you want? What is happening from echo?
So there is an LV dysfunction. Certainly,
Yes.
it is a cardiogenic shock,
Yes,
and the lung
yes.
fields are also plethoric on the
Yes.
X.
So it is a yes.
So it is a.
So why this baby at day 24 should go in cardiogenic shock? Anything else, extra investigations you want at this stage? Okay, we did blood gas also. Just comment on blood gas, and this was just before starting this inotropes and all, before putting CPAP.
Again, it is in metabolic acidosis, sir.
So it is in cardiogenic shock. That's why these things were there. Acidosis is there. So we'll ask our experts what is opinion at this stage. First we'll go to madam and then we'll go to doctor. Yes, madam.
Yeah, so definitely the baby's condition has again deteriorated. His gases have worsened, and the baby has cardiogenic shock. And how do we explain this LV dysfunction at this point when the PDA is already closed? So
Yes.
what can be what is the cause for this LV dysfunction, which right from the beginning we were wondering, was the PDA, the large PDA, 2.5 mm is a large PDA with left to right shunt, whether PDA was causing the LV dysfunction? And how commonly we see LV dysfunction with PDA?
Yes.
And now that the PDA has already closed, how do you explain this LV dysfunction? Sepsis can contribute to LV sepsis. If it's there, it can cause LV dysfunction. That also, we are not very convinced that baby has sepsis here. So we need to think of any other metabolic events causing the responsible for the LV dysfunction, I think.
Okay.
And the lactate is also quite high, 8.4, which is quite significant. We don't see this kind of lactate normally even in shock with the newborn babies, pure septic shock, etc.
So first, what is your take at this stage? Baby going in on day 24 in cardiogenic shock and this kind of deterioration.
See, I'm looking at from clinical picture to the lab.
Yes.
Clinically, child has acidotic breathing, which is pretty significant. Then there is a background of recurrent hypoglycemia.
Yes.
Even now, the sugars are 45 for
Yes.
day 24. And then there is increasing lactate. From 4, it has gone up to 8.42, persistent metabolic acidosis. And now it is becoming high anion gap acidosis. So I think we need to look at, and with CRP negative, 0.45, I think that is pretty significant. If you even the blood counts are also normal, and your echo showing significant LV dysfunction, I think we should think in terms of cardiomyopathy, secondary to some inborn errors of metabolism.
Yes.
Though our first newborn screening test, which was done,
yes,
was it a limited profile, or we did?
Yes, it was limited profile.
So that's why I think we should keep that in mind. It was done quite early in the disease. Around day 16, we had done
day 7. Day 7.
Day 7. It is quite early for the preterm babies to do in the first place. So
Yes.
sometimes it can mislead us.
Yes.
Either way, either it can be, it won't pick up the diagnosis, or sometimes it will overdiagnose also, because some of the metabolites are not metabolized by the preterm liver. So you can see high values also. So we have to repeat anyway, as per the protocol.
Okay.
Just one thing for PG side. Can I say one?
Yes,
Yeah,
yes.
at this point, I would see what would be the urine ketones, which you have not mentioned in
Yes.
any of your, which is a
Yes,
simple
this time we did urine ketone was just 1+, serum acetone was just borderline, and ammonia was 90.
Okay, okay. So ketones was not much. There was not much significant ketones.
Yes,
Yeah.
yes.
So we are looking at recurrent hypoglycemia, high lactate, and
Yes.
probably not much of a ketone.
And
ketone.
significant cardiomyopathy along with it.
Yes,
Yeah,
yes,
probably.
cardiomyopathy. Yes. So then this was done at 10:30 night, and we started with support, and day 20. This is just after 6 hours, early morning, 6 a.m. This was the blood gas. So this was from 7.305 to within 6 hours 7.038, PCO to 21 here, and lactate has gone to 10.49. Here, yes, there is.
Were you giving bicarb? You were correcting the acidosis?
Yes, it has correction of acidosis has started, and we have, but maybe had required very high dose of adrenaline also at this stage. So what did we thought at this stage? Yes, maybe contributing from some kind of part from adrenaline. And now PGs, I will ask you at this stage what you will do. Now we know this is a metabolic acidosis, high lactate. How will you start treatment? As both the experts have said about some IM component is there, though our screening test is negative. So what will be your approach? How will you start treating this kind of severe metabolic acidosis?
Bicarbonate correction for the same.
Okay. Bicarbonate, how will you give? Will you give just boluses? Will you start drip? Any other things what you can usually suggest do at when you suspect inborn error of metabolism?
Sir, if the baby is on feeds, we can keep the baby a NBM.
Hold, yes, correct.
And as ma'am said, bicarb correction also we can consider.
Yes, yes.
And sodium benzoate.
No, there is ammonia was normal, so there is no role of benzoate here at this stage. Usually we start this was the thing we started. We send a TMS blood, GCMS urine, plasma amino acid, acyl carnitine profile. We started as both experts suggested bicarbonate drip, and we started on carnitine drip also. We put on this baby on biotin also. So this was on day 25. So this day 10 to 26, what investigations come to us? Pre-carnitine was very low, elevated C10, 14. Acyl carnitine profile was abnormal. Fatty acids were normal. And if you see, organic acids were markedly elevated. And what we got impression or from this, what we can interpret this is multiple acyl co-dehydrogenase deficit, what is called as glutaric aciduria type 2. So this simultaneously we send genomic sequencing for this thing. Now, expert, what do you, how will you go about this case? Now we have got biochemical diagnosis for this case. Madam, first I will come to you, then we go to Vinay.
Yeah, so there is something very significant here, that is low carnitine and significantly elevated acyl carnitine profile. So there are a few conditions where you get that. The most important being fatty acid oxidation defects, where you can have hypoglycemia and hypo or no ketosis for that matter, and this kind of acyl carnitine profile, which is very high. So I would consider a fatty acid oxidation defect in this child. What goes against an organic acidemia, probably there is no ketosis. In organic acidemia, I would have expected ketosis. I would have expected hyperammonemia.
Yes.
Although hypoglycemia. So between the two, I would go for fatty acid oxidation defect in this child, considering the hypoketotic hypoglycemia and this kind of carnitine profile.
Yes, Vinay, anything extra?
No, I think we'll go with the fatty acid disorder and just wait for the proper report to come to us so that we can intervene and we can do some dietary changes.
So this was one added thing what we did. All riboflavin was added for this stage, and this is the how we did This glutaric aciduria type 2, which is usually, as Vinay was saying about cardiomyopathy, was a component of it. Kidney abnormalities also were there. But though there was no specific odor or as such we could able to find. There are severe hypoglycemias were there. Respiratory distress also was maybe component of it. And but this baby didn't have any large head, or they specifically have this fat nasal bridge and malformed ears, and and it is quite fatal, as this is a neonatal. If
Yeah.
it get in first 4 week of life, it is quite fatal. But as per report has come now, biochemical things were also there, and because this was a baby 28
Eight.
8 days baby, you just imagine how the pressure from the parents were there. We were counseling almost one hour night, almost 2-3 times we counseled, and at this stage we really told them that this is how the things looks like, prognosis looks, but day 27 this is looks like. But what we found is there was clinical improvement. Clinical signs were improved, tachypnea has reduced, perfusion was better, and distension has reduced. So we are given this, though clinically there is maybe some improvement is there, but biochemically this patient is like this. And we have already sent genomic sequencing. Riboflavin was also added for this baby. And we have really to say, anyway, sir, we have gone through so much agony, and now 4 weeks are there. Because you say clinical improvement, will go with you and will continue the treatment. It was surprise to us on day 28, this tachypnea has improved less, perfusion has improved, echo surprisingly within 24-48 hours, with minor dose of milrinone and dobutamine. The ejection fraction improved, TR was there, but here again the lactate has improved, though clinical improvement is there. So PGs, what is happening to this baby now? Yes.
So the acidosis part, which was there persistent before, has now improved. And as you
Yes.
said, the lactate is higher than what was before. So, which
Yes.
is one of the metabolite which still goes in favor of some, let's say, fatty acid oxidation defects.
What do you want to intervene at this stage? Because clinical improvement is there, but lactate has gone up. So you want to intervene at this stage? What is your take? As coming to, you have seen the baby prior also, you have seen the baby now also. So what is your take?
So I get, yeah, so we can wait because there is clinical improvement, and we have
Okay.
also added the riboflavin.
So what feeds you will start to this baby? Now this time has come, now baby is better. What feeds you will start? Okay, we'll go to experts for this. Yes, madam, this is now day 28. Within 24 to almost 36 hour baby has showing now signs of improvement. We have started initially 5% dextrose feed to this child. Lactate is improved. So what is your take? I will first.
Yeah, no, definitely the acidosis has improved and your bicarb therapy has worked. Clinically, the baby has improved, but lactate is 12.72. But I wouldn't worry much about the lactate because now I'm pretty much sure that it's a metabolic problem and the lactate is going to take time to come down. Keep
Yes.
giving your bicarb. Don't go down on the bicarb. I would continue the bicarb on this child. Coming to the feeds, I don't have, if it's a fatty acid oxidation defect and if it's not really organic acidemias like any amino acid metabolism, I can still continue with feed, but maybe probably low protein. Slightly, I would restrict protein rather than completely stopping, because at this point, I don't think if it's it was unlikely to be organic acidemia. We are looking more into fatty acid oxidation defect. So in that case, I would start the baby, small feeds would continue, maybe low protein, like some.
Vinay, your take?
Yeah, I think, and continue all the supplements which we were on.
Yes,
Don't
riboflavin,
stop. Very,
carnitine,
very,
and
very important.
supplements.
Carnitine, your riboflavin,
Yes.
bicarb. See, I think that typically the way this child is presenting, whenever the child goes into stress,
Yes.
child
Exactly.
worsens. The
Yes.
moment you take away the stress, the child gets better. So I
Yes.
think this is the typical presentation. I think this alkyl-CoA dehydrogenase deficiency patients present, and the presentation is metabolic acidosis and acidotic breathing with
Yes.
other
Components. Yes.
yes.
So this was the child started on skim milk. Tarnisure, biotin, and riboflavin was there. Day 30, only mild TR was there. Yes, you can see between day 28 and day 30, lactate has significantly dropped, pH has improved, PCO2, and this is the video of a baby. See, from within 48 hours, this baby has started crying, go vigorous. Inotropes have gone down, and day 43, feeds were increased, tolerating food feeds. Day 43, baby has weight gain also was 1.24 kg. So this baby what followed up day 50, baby's weight was 1.34. Day 56, weight was 1620, activity fair, baby gaining head circumference. There was no evidence of, because almost now baby is 7 weeks now. We sent this repeat metabolic workup for this baby, and surprisingly no ROP, OE passed, and parents happy. And this is thing has come. Pre-carnitine is now, yes, baby is on quite good carnitine support, riboflavin support. So this GCMS of organic acid almost normal, amino acid plasma also normal. So this is pretty. So now I will take comment from both experts. First we'll go to Vinay and then we'll go to Madam.
No,
So what has happened to this child overall?
if you go back to the previous one, yeah. See, most of the things have come normal in this,
Yes.
right? And your LFT is normal, PET, INR is normal. Yes, and there is mild elevation of some amino acid that we normally see in the preterm babies. That's what I was
Yes.
saying. Whenever you
Yes.
do a newborn screening test in the preterm babies, you have to be very, very careful when you interpret those.
Yes.
Okay. And even acyl, the profile has come positive, your acyl carnitine profile, maybe because we are on good support of carnitine and all that. So I would keep that into account, and I will repeat this maybe down the line, continue same treatment for this baby. But now I will monitor the baby closely neurologically as well.
Yes. Yes. Will you shift this, Vinay? Will you shift this baby to routine feeds, or still you want to give?
See what happens, I tell you, whatever you do, you have to do it very gradually. With time, the most of the enzyme levels are going to come, they increase as the baby grows. So
Yes.
I think that is the time we should be, probably, I don't know exactly at what stage you will do it, but
Yes.
rather I will follow this child very closely, especially with the weight gain and the milestones, etc. Continue same kind of treatment for now. I will repeat the test again, maybe down the line, 3 months or 6 months. Sometimes, I followed up a case up to 1 year.
Yes.
And then
Yes.
subsequently, the child went on to the normal diet and everything turned out to be normal.
Yes. Madam, your take.
Yeah, as he rightly said, see, the carnitine profile is normal here. So that I would say always we must remember in metabolic is that, see, the reports, the utility of the reports is when the baby is in a catabolic stage. When they're in an anabolic state or when their things have become improved, you might not get abnormal values.
Yes.
So probably the baby has improved with the bicarb and carnitine and everything. And you are getting the acyl carnitine profile is absolutely normal here, which was very significant. So definitely there is a metabolic problem here. And we have treated it. That is 100% sure, because you won't get such lactate. You have all the clinical presentation. We know it was not sepsis. The baby was
Yes.
always active. See, for the PGs, how will you differentiate? The closest mimic of a metabolic disorder is sepsis. And we always tend to do sepsis. Many times we burn our finger and slowly we learn that it is. I'm sure this baby might have gone on very high antibiotics, which Vinay has not told us. He might have gone on to all the highest antibiotics.
Yes, we gone to up to piperacillin tazobactam.
Yes, I don't know, but it is possible. In any other place, this baby would have been on high antibiotics, even though it was not really sepsis. So that is one thing which students should always remember. And when you interpret the reports, you should see the clinical status. You should always do when you have a clinical manifestation on when the baby is in a catabolic state. Just doing it on a normal person, even if you have a metabolic problem, especially disorders like fatty acid oxidation defects, organic aciduria, that will get precipitated with stress. Yes. So now baby is in a controlled anabolic state, so you are getting a normal acyl carnitine and carnitine profile. So, but we will keep the first one as the correct, and we will still keep him in line of probably glutaric acid type 2. Yes. Now coming to organic aciduria and this amino aciduria, both, as Vinay rightly said, there is immaturity of the kidney as well as liver. So that is why this is called as the renal aminoaciduria, what you get in these preterm babies. So don't bother, you will get whole lot of this kind of amino acids positive if you do preterm babies. Even a normal preterm baby's urine, if you do, you may get this. Even this thing which they have written normal LFT, sorry, some liver disorder, and you have some 4-hydroxy phenyl lactic acid and pyruvic acid. All this can also be part of, you must understand that the metabolism, particularly of tyrosine and phenylalanine, are little bit compromised because of the liver immaturity in these babies. So this is all part of immaturity. So we should, now coming to the question of how long to continue, I would probably continue this baby on the same skim milk because I'm not too sure how he's going to tolerate. He may grow over it, and we will definitely tell them to avoid fasting and giving very high protein diet, and we will follow up. Maybe this is a milder, again in the IEM, we must know that all phenotypes are not same.
Yes.
You get much milder phenotype and the very severe varieties. Though this probably is one of those little bit milder phenotype of glutaric aciduria, which Vinay, you said that it is fatal prognosis, and we already predicted bad prognosis to the parents. But contrary to our expectation, the baby has improved. So I would be forced to believe that this probably is a milder variety of glutaric.
Okay. Yes. So we did literature search for this, and this has come like maternal riboflavin deficiency resulting into the transient neonatal onset of glutaric aciduria type 2. So they have definitely case publications are there where you get a everything is picture fits in like this. But these are what you call as a transient neonatal onset glutaric aciduria. So there are multiple reports on this. So this is the newborn female, because yes, riboflavin of this mother we have said, this is basically she is being a purely vegetarian lady, and she has been restricted diet for because of her pregnancy and their cultural issues. She has not been allowed routine diet for a very long time, and there are multiple reports are there. So this is few reports I got, and what right now we just till we get exome sequencing report. So what I want to finally conclude, this may be a transient glutaric aciduria type 2, may be related to the maternal riboflavin deficiency. So that's what from me today, and thank you very much. And before going to conclude this session, actually I thank both the PGs. They are very nicely we are going all the path, and very congratulations to their mentor also, because it suggests the approach has been told by the how you have been undergone the training. I'm very happy. It is from Kolhapur. Has been Dr. Nivedita. Thank you very much for training students like this in a very.
I want to say something.
Yes.
Yeah,
Yes.
that was a very nice case. Coincidentally, we have one such case in our NICU as present, and Rupal is working in NICU. See, we always tell them if it looks like sepsis and you don't get the sepsis screen positive and the blood culture is negative, you should always think of IEM. And that was a very good case. I think if I'm not wrong, in first ABG itself, the anion gap was wide.
Yes, it was there.
That
there
was
are a lot of pointers were there right from the beginning. So
Yes.
some pointer, and this actually, if you see, baby deteriorated actually when we started on female MCT. Right?
Yes.
To be very
Yes.
frank, right from the day we started, and within this next 48 hours, the baby has deteriorated. That may be one of the contributing factors. Hypoglycemia was there in between. As Vinay has really pointed out, there was that cardiac function. We right from day one, we were not able to explain why this baby was going in recurrent cardiac failure and up to level of shock, and transiently improving immediately. So I've never seen 3 to 4 times to requiring dobutamine, milrinone, adrenaline to start and stop within span of 3 weeks. This was quite interesting. Then I will take one comment from first. I'll take a comment from Madam overall about this case, and learning of points or take home points to the PGs, and then I will come to Vinay. Yes, ma'am. Unmute, madam. Unmute yourself. Madam, unmute yourself.
Ma'am, try now.
Yes, I got it. Yeah. So I think it's one thing is that you should always think laterally. You should never have that one line thinking. It's only, one diagnosis. The PG should be able to think wide, should be able to consider all the possibilities, and very serial, stepwise, and meticulous analysis of the clinical condition of the baby and the interpretation of the lab. Many times we send labs and we don't bother to interpret that lab so meticulously. We just do one general assessment. But then I think it's very important that, we dissect and interpret the labs very minutely, so that many things may come relevant at that time, which, at that point of time, we may not have a diagnosis, but when you follow it up, you will definitely come to a diagnosis. So that is what, and basic things like approach to a hypoglycemia and approach to basic of a inborn error of metabolism, the algorithms, I feel all PGs should be well versed with.
Yes, thank you, ma'am. When a last comment from you, and then we'll continue.
Okay. I think it was an excellent case. Thank you very much for involving me in the discussion. So, and I really thank the PGs who presented this case and their mentor as well. Take homes, basically, don't forget the basics. I think your history, your clinical examination, and small details are very, very important. And try to put the things together like a puzzle. I think that is very important. The small findings, if you put everything together, we reach to a diagnosis. And if we, as you rightly said, interpret the labs carefully. I think preterm babies, they stump you with, different presentations, and their labs are, you have to look at the baby, you have to look at the number, interpret, taking into account their gestational age. I think it is very, very important. I think that's it. Wonderful. Thank you very much.
It's a nice case, yeah.
Yes. Thank you, both experts, PGs and their mentor. It was a very nice discussion with all of you. Yes, all other participants also, we are getting good comments from this. And this is 2 points as a thing I would like to say, always do blood gas analysis very carefully. So always, whether it is real acidosis, how much it is corrected, if it is acidosis, try to go with what type of NN gap, whether it is mixed disorder, then try to dissect this. Don't try to interpret blood gas in a very superficial way. Lot of things ABG associated can give you a lot of clues in now today era. And point of care ultrasound, this case actually, because of echo and other things, our things was very easy. And because labs, all this supportive investigation in the light of clinical science, what all our experts are saying today, we always try to see clinically and try to interpret and be persistent on that case. When pH of 7.03 came to me, that was actually, we had almost give up, but we should not give up at this stage. But though whatever serious conditions can come, especially when you work in NICU and PICU, these are the life-threatening things to come. Be persistent on that, be basics, be remain with your basics and clinical acumen, and optimistic view with all resource available now. All of you are lucky to have point of care ultrasound and point of care labs and good teachers with you. Try to get habit of it. This is your beginning of career. Then you can become a good kind of a clinical person as well as a good treating pediatricians. Thank you very much, all of you, and my core team of Case Live book. Maybe 1 month later, we'll come up with one more interesting case. Till then, signing off from Casebook Live.
Thank you.
Thank you.
Good night.
Good night.
Good night.